Hello, everybody. Thank you for joining the Systems for Action Research in Progress webinar. I'm Chris Lytle, Deputy Director of Systems for Action. For folks new to the program, S4A is a national research program with the Robert Wood Johnson Foundation, housed at the Colorado School of Public Health. We support studies examining multi-sector collaboration across medical, social, and public health systems with the goal of improving population health and advancing health equity. So today we're joined with a team that's just been recently funded in a cohort of studies who are interested in system alignment issues during the COVID-19 pandemic. They'll be exploring the effectiveness of early childhood development partnerships in addressing pediatric health and social needs during the COVID-19 pandemic. Next slide, please. So we'll start off with a brief presentation from the team based at New York University, followed by commentary and Q&A. So as you have questions, feel free to include them in the Q&A box on the bottom of your screen. And we've reserved some time at the end for our presenters and our commentator to respond to your questions. So first, I'll start off with a quick introduction of our presenters. Dr. Paul is an assistant professor in the Department of Population Health at the New York University Grossman School of Medicine. Her work is primarily focused on evaluating innovative primary care-based interventions that address health disparities, often via multi-sector collaborations. And Dr. Berry is an associate professor in the Department of Population Health at NYU Grossman School of Medicine. For over 20 years, she has evaluated policies and policy relevant programs in public health, healthcare, and social services with a focus on poor and underserved populations and health disparities. Rachel Masser is the research coordinator in the Department of Population Health at the NYU School of Medicine. She works on several evaluation projects and is involved in the design of data collection instruments, the management of survey administration processes, treatment and comparison groups, and the analysis of survey data and qualitative data. And we'll have commentary from Dr. Pradeep Gidwani. Dr. Gidwani is a pediatrician and community health leader who works at American Academy of Pediatrics, California Chapter 3, San Diego, and Imperial Counties, on a team that provides countywide coordination and support for two large-scale community initiatives, Healthy Development Services and First Step Home Visiting, funded by First Five San Diego. So with that, I'll hand over controls to our presenters.
Okay, thanks, Chris. Just want to test. Oh, there we go. Okay. Great. So, thanks for the welcome, and thanks to the entire S4A team for helping us prepare for today and for connecting us to this wonderful community of grantees and all of you today through this webinar. Of course, we are studying, as researchers, we're studying this collaborative, which is a series of partnerships, and we'll talk a lot about that today. But I also want to underscore that it took a lot of partnership and collaboration to get this initiative off the ground. And that work was spearheaded by the team at the United Hospital Fund, who founded this initiative in April 2017. The collaborative is chaired by Dr. Bernard Dreyer, who's a pediatrician and a leader in this field and has done a lot of important and policy relevant work on social determinants of health screening and referral programs. And the overarching goal, the big picture goal, is to improve the health of well-being for families living in New York City with children under the age of 5. And so the way that is being done through this collaborative is by initiating or strengthening, in many cases, existing partnerships between clinics, pediatric ambulatory care clinics, and community-based organizations in New York City. And so while the details of any given program vary a lot, they are all identifying social determinant of health needs among families in the clinic setting, or through a patient portal up front, and then connecting families in need to community partners. And so so that's the gist of the program, and but the overarching goal is really to this focus on health and well-being among families with young children. This collaborative and our work as researchers is supported by a group of funders that the United Hospital Fund brought together. And this has really been a wonderful partnership, and this has been a uniquely supportive bunch, I would say, with regard to both the program side, actually supporting the collaboratives themselves, the partnerships themselves, but also supporting our work. It's rare as an evaluation team to partner with program implementation side so early on, and we really came in at the start of this program. And so it's been a really wonderful experience for everybody involved. This slide presents, shows you the network of PECD screening and service delivery providers. And so, you know, as you can see, and those of you who are familiar with New York will kind of get from this that Manhattan and Brooklyn are well represented. We even have collaborative partners out on Long Island. And so even though all of these partnerships are based in New York City, they all are operating in very different contexts. And so everything from the target population to the resources available in the immediate community vary quite a bit from one site to another. And so, you know, as you can imagine, you know, a site out in the far Rockaways is very different from a site in the Lower East Side of Manhattan. And so, so all of that's to say, even though this is being this work is being conducted in the same community, broadly speaking, I think we're seeing the importance of local, like very immediate local context popping up. It's also worth mentioning that while these clinics and their community partners are actively engaged in or formally engaged, I should say, in the collaborative, each of these clinical sites, in some cases, the clinical sites are partnered with more community partners than are listed here. So, and it's also the case, especially since the pandemic hit, which is, you know, shocking to say almost a year ago, there has been some turnover and churn among the community partners. And so this is a current list. It's changed over time, and it may not be comprehensive in any particular site. I'm going to talk a little bit about the phase 1 evaluation activities that our group was engaged in a few years ago, and then I'm going to turn it over to my colleague, Rachel Masser, to talk about our more current work on this initiative. But the early work that we did really required a strong partnership with the sites involved to make sure that we got all of these pieces right. And so we had input from sites and the collaborative more broadly as we developed an overarching logic model for the screening and referral network. And so this, for those of you who are familiar with logic models, this will look familiar. This is going to look very foreign to anybody who has not worked with one before, but I think that logic models are a really excellent tool for both the program implementation side and also, of course, the evaluation or study team, because it really is a way to think logically about your program and lay out the steps, everything from resources to longer term outcomes that you're interested in. And as an implementation team, it can be useful if you start to see that you're not getting the outcomes or even outputs that you imagined. This is a great tool to use to revisit what's going on in your program and identify areas for programmatic improvement. And so we created this general logic model for all of the sites participating in the collaborative, but then each site took this and made it their own and modified each of these to be more specific to their site, and even included some goals for screening and so forth. And so from a, you know, related to our project with S4A, it's important to take a look at the underlying assumptions here and understand the system level factors that place limits on programs like these. And so the work that we're doing on this S4A grant, as Chris mentioned in the introduction, is really laid on top of the evaluation work that we've been doing in partnership with the United Hospital Fund. And one of our goals for this grant is to really understand system level factors that facilitate these clinic community partnerships. But it's important to understand that the goal of this collaborative network is not to increase or necessarily strengthen the safety net. I think there have to be resources available in the community for CBOs to connect families with. And so that's a really key underlying assumption, especially in the era of COVID, as we've heard through our qualitative work, in which CBOs are starting to run up against barriers to limits of resources in communities, especially with respect to housing and that sort of thing. And so all that's to say that this is a general logic model for the collaborative. Each site has created their own specific logic model, and we're not presenting those today, but we are going to have an extended Q&A session and are happy to answer any questions about nitty-gritty details that you may have to the best of our ability. The other important piece of work that we did during the first phase of our evaluation was to identify key implementation measures to capture progress across all of the sites. And so even though the workflows differed and important aspects of the program differed, I don't want to downplay that, but we decided very early on that there was high value for both the sites and for the study team and the broader learning collaborative to understand what these measures were from each site. And so, of course, the screening rate seems like the most basic measure that one could capture with respect to a program like this. It's the proportion of individuals in the target population who were screened. Then we also asked sites to track positive screens and as well as miss positives. So individuals who may have, say they're being screened by a medical assistant in the waiting room and they don't report any needs. We were hearing anecdotally that some parents were then going into the exam room and reporting needs such as food insecurity, for example, to their provider, even though they didn't feel comfortable writing that down on paper. And so in some cases, sites were able to refine their workflows to get more candid responses on the screening tools themselves. We also took a look at, those out of the positive screens who was referred, took a look at refusal rate, which was low across all sites. So individuals who refused services after being referred. And then, of course, wanted to capture service provision as well as referral feedback. Referral feedback is sometimes referred to as closing the loop or closing the feedback loop. And this proved to be one of the more difficult measures to capture because of the different data systems that were used by the clinical team versus the data system and tracking system that the CBO had in place. And so that was a really tricky box to check for a lot of sites, as well as actually, I will say that the screening rate, even though it sounds like the most basic measure you could capture, was difficult because the denominator actually is quite difficult to define given the flow of patients in a clinical setting. So, how do you account for missed appointments? How do you account for walk-ins who are screened and so forth? And so that ended up being a stumbling block for a lot of sites. And so in addition to developing these measures in partnership with sites, we also provided technical assistance to them and helped them refine their data tracking systems to, make this work as easy as possible, this tracking as easy as possible going forward. Okay, I'm going to stop there and turn it over to my colleague, Rachel Masser, who's been really directing this project and is very much in the weeds with the parent survey that she'll talk a little bit about down the road. So Rachel, I think I'm going to retain control of the slides. So just let me know when you want me to advance.
Okay, sounds good. Thanks, Maggie. So I'm going to talk about our phase 2 and phase 3 evaluations, as well as our Systems for Action project. So for phase 2, we conducted a process evaluation for 4 selected sites where we did 2 rounds of site visits and key informant interviews. And in order to select our 4 sites, we wanted to choose sites that had a mix of various levels of resources available for implementation, and then also a history of partnership with their CBOs. So there was one site that had high level of resources and a strong history of partnership with their CBO, one site that had high resources but a more recent partnership, one site that had a lower level of resources but a strong history of partnership, and then another site that had a lower level of resources and a more recent history of CBO partnership. And so we visited each clinical site in person. That was back before COVID, obviously. And sometimes also we were able to visit the CBO partner site as well, or in some cases they came over to the clinic to speak to us. And so we interview these key informants from the clinic side as well as the CBO side to really get a sense of how the program was working on the ground and identify the challenges, barriers, and facilitators. We then revisited these same sites a few months later, speaking to the same people to see how things had changed from our first visit, what changes had been made to improve the program. And oftentimes the programs did look a lot different on our second visit compared to the first visit. And so we also conducted some additional interviews virtually with clinic sites this past spring after COVID hit, just to understand how the programs were functioning during the peak of the pandemic in New York City. Next slide, please. All right, so our key findings from these site visits. So as far as implementation, this work is possible, but it's also really challenging. It requires real partnership between clinics and CBOs with open and frequent communication and a substantial investment to establish capacity and integration into existing workflows. So one of the key lessons learned was that clinics really needed to think through and test out the best way for them to integrate screening into their workflow and make it really a routine part of their operations, not something extra that could be forgotten. Also, integrating screening into the EHR system was really valuable, especially for tracking purposes, also allowing providers to see the results from the screening. And then it was also really important to have that person power in the clinic, to have someone or maybe multiple people that were really dedicated to managing the workflows, managing the partnerships with CBOs, and just ensuring that families were not falling through the cracks. Another key finding was that establishing trust with parents is also possible, but again, it takes real work and it needs to be approached thoughtfully. So these are sensitive topics that the screens are asking parents about, and some parents are just not comfortable filling out the screen. So having someone there to explain the purpose of the program and build that trust with the parents was really critical. And then as Maggie talked about, it's also really important to consider the contextual factors, including the availability of services within a given area, because that really dictates what social needs the clinics could screen for. They weren't wanting to uncover a social need that they then had no resources to direct a family to for help. And then the impact of COVID-19. So we also learned a lot about how COVID was impacting these programs really during the peak of the pandemic in the spring. And there was a big jump in reported social needs, most of which stem from poverty. So things like cash assistance, rent assistance, food insecurity, childcare needs. These needs all increased dramatically as a result of the pandemic. And there's now really a heightened awareness of the value of this work, but it's unclear how and if this will translate into long-term changes throughout the collaborative in terms of program and policy implications. Next slide.
Sorry, it froze for just a second. I think it's going.
Okay, so now we'll talk about our phase 3 of the evaluation, which is an outcome evaluation. We're very much in the thick of it. So we are conducting parent surveys of parents who have screened positive for having at least one social need at baseline, so right after they're screened. And then 6 months later on a variety of proximal outcomes, and I'll review those outcomes on the next slide. And then we are also conducting more key informant interviews with the clinic staff and the CBO partners. Just doing a final assessment of the status of the program and understanding the final lessons learned there. We also plan to conduct parent focus groups to learn more in depth about their experiences in being part of this screening and referral program. And of course, everything is now in the context of the pandemic. So we've been able to add some questions to the survey on the impact of COVID-19. And then obviously we're also asking our key informants about the impact of COVID-19 in our key informant interviews. Next slide. Okay, so these are the outcomes on our parent survey. And we chose these outcomes after much discussion and collaboration with both UHF and also talking to the sites about what we all wanted to look at together. And we had to be realistic about what we could actually expect the program to change in about 6 months' time. So we landed on the outcomes that you see listed here. So asking parents about their social needs, their engagement with the community partners and services that they received, time and ease of getting their needs addressed, the parent-reported child health, parent self-reported health, developmental and behavioral concerns about their child, missed work days, child absenteeism from school, parent stress, parent depression, parenting self-efficacy, their satisfaction with the screening program, also their satisfaction with the institution and the clinic more broadly, their perceived access to healthcare, and then finally the impact of COVID-19 on their lives. Next slide. So now onto our Systems for Action project, which is really building on all the work that we've done thus far. So our goal is to assess COVID-19 related implementation changes at each site and across the collaborative network as a whole. And as the pandemic rolls on, things look differently than they did in the spring. And the programs are really having to adapt to this kind of new normal way of life, still continuing this work, which is more important now than ever. But there's really a lot to learn about the resiliency of these programs in the face of this crisis. So our approach will be to do more key informant interviews, but we're going to expand our net and include some new key informants, such as leadership at the institutions, to get more of a systems level perspective of the work, and also including our usual cast of key informants from the clinic staff and the CBO staff. And then we'll be doing those focus groups with parents, as I mentioned before, to understand the perspective from the target population on system functioning, areas for improvement, from the screening process itself to receiving the services, and then the follow-up thereafter. And then we'll be doing analyses of those core implementation measures that Maggie talked about. So the sites are still collecting that data, and it'll enable us to get a quantitative picture of the extent to which the COVID-19 pandemic has impacted demand for services throughout the crisis and the overall functionality of the existing system with respect to identifying, referring, and addressing the needs of families. So we are excited for the work that is to come. And with that, I think I'm turning it over to Dr. Gawande.
Good morning, everybody. My name is Preexisting. I work in San Diego and have had the unique opportunity to spend the last 15 years working on a project where we treat kids with mild to moderate developmental and behavioral concerns. So while our program is not exactly like the program that's being discussed, we have learned a lot of lessons, and I have some commentary on what we've heard so far and how exciting this work is. And in addition, I also am medical director on a home visiting program, a Healthy Families America model. So there's some really interesting pieces that I'd like to share and some thoughts just to think about how do we reach families. So first and foremost, I think this is amazing to see how we're transforming pediatric care. And I think the important part is understanding the social determinants of health is something that pediatricians have always felt is important. However, we can't do all of the work by ourselves. And one of the projects we're working on here is actually linking our pediatric offices to those resources in the community. And it feels like you all are farther ahead on that. So I applaud you for that work. One of the challenges that we have found is when we started offering services 15 years ago, families would come maybe come, maybe not come, and they would stay engaged or they wouldn't stay engaged. Well, at the beginning, we were very focused on building a system, making sure we had the right services in place, but we realized that we had to go further with our care coordination and case management. And particularly when we started working in early childhood mental health and taking a greater focus on that. So a couple of things I want to share with you is one of the things I think is really effective is understanding that screening is just a first step. We know that. But one of the reasons we're all reluctant to screen is what do you do once you screen positive? So again, these linkages are so important. Also, the amount of work that it takes to get this to happen is also critical because these are dollars that aren't paid for. However, we know this, the impacts and the benefits to society can be so great. So one of the other things I'd ask this group to do is to really start looking at quantifying how much work does it take? And that's going to require all of you on the front line leaning in and helping us understand what is the time commitment? What are the barriers? The electronic medical record can be very useful, but it can also be very challenging. And sometimes we have to actually build the relational components first and then have the technology support the relationships rather than trying to have technology be the relationship. And that's actually where I want to spend most of my time is really thinking about what are the key aspects about relationships that really help our families. And that's really what we spent a lot of time working on. We have a 3-tiered system of our, what we would call our care coordination. Our first level is simply the referral management component. The second is case management. And then the third level is intensive case management. Of course, we're using a trauma-informed lens, but to get to a trauma-informed lens, we've also made sure that our providers get reflective practice, which is a way of them having at least an hour a week in group and hopefully individually as well, to really reflect on what things are triggering them, what is coming up for them in their day-to-day lives. So many of our workforce have traumas of their own and have issues of their own. So again, this is a really healthy way of helping them. It reduces burnout. It also makes us more compassionate. So that's one component, as well as motivational interviewing. The other part is our work really focuses on the strengths of families. And so again, strengthening families, that framework is a beautiful framework with a lot of evidence behind it. And we're also now just incorporating some work around hope, health outcomes through positive experiences, and Bob Sege's work out of Boston. So there's some really important pieces to think about as we're building systems. But again, one of the key components that we have really found is there's some key questions that our families, I call them the unasked concerns. And so parents have a concern. The first one is are you safe? And again, that safety piece is really the essential of trauma-informed care. And again, there's so many opportunities to really kind of rebuild the attachment relationship with families through helping them feel safe. The next question is they really want to know, can you see me? Can you really see me in what I need? And I think, again, the tools are important as well as having an approach that really helps the family feel seen and heard. Another component is will you be there for me when things get tough? And I think we have to be ready for the resistance that many of our families feel like you may not be there for me when I need you because they've had problems in the past. They've been disappointed in the past. And also they want to know, are you competent? Can you really help me? So again, I think we really need to have a way of looking at this. And I think the other part that's really encouraging here is that the pediatric office can be such an important place of safety, of resource, and pediatricians can be like the captain of the ship, the captain of the team. And really, we need a team approach. No one individual can do this. And again, families will connect with and feel connected to different individuals within a practice. And so, again, the key piece is helping them build those skills, building on their strengths, helping them with that parent-child interaction, helping them feel their own abilities as a family. In our work, we've been surprised by the incredible need for legal services. And so again, when we look at things like the medical legal partnership that Barry Zuckerman started many years ago, these are such critical elements. And again, I really applaud the work that's being done here. And again, that component of how much time and effort does it take to coordinate families, and seeing families on a continuum of needs becomes really important. The higher most of our higher need families have a significant trauma history. So really bringing back those pieces of how do we really help families move forward? How do we really help them move forward? I think our home visiting programs also offer some really great insights. And just leave you with the one thought that with our Healthy Families America program, one of the incredible parts about this program is we do an assessment when we first meet the family to see how they fit for our program. And when you're trained to do this assessment, you have to do the assessment as a conversation, and it has to cover all the elements while still at the same time maintaining that you cover the key elements. And so what really happens is the family feels like it's a conversation. And when I was first trained in this, I thought, oh my gosh, I'm going in to ask these questions of a family that I've met for the first time. Wow, I don't know how that's going to work. Well, what turns out to happen is the families really believe that if you're willing to ask them about those questions about their lives, they're more likely to think you care about them. And it's true, we really do care about them. And with that, our rate of people taking up our program when offered is incredibly high. And when we compare it to other programs, it actually shocks me how well we do. And so again, I think the component of caring and being able to have the courageous conversations with families really can make a huge difference. And again, I'm just so excited to see this work, and I'm really looking forward to this next level of evaluation that's coming through, because again, the answers that we're looking for will not come through on a survey. It will come through these focus groups. It'll come through key informant interviews. And so I'm very excited to see how this work is progressing and really how we can spread it. And more importantly, how can we get a sustainable funding source? Because I know that this kind of work makes such a huge difference in the lives of kids and families. And it really takes our approach as pediatricians, it really kind of marries that combination of our medical and our public health perspective. And as you can see, I have both an MD and an MPH. And so to be able to hear about the work that you're doing and to look at the breadth and the depth of what you're doing is fantastic. I think also what's going to be really interesting in the evaluation is to see what services really help families the most and what helps families feel supported. And one message we give all of our families is all families experience stress and all families deserve support. And COVID has just amplified that need. And so again, I'm very excited about this project. I'm very excited about this work, and I will leave it there so we have time for questions.
Thank you, Dr. Gidwani. We will move on to our Q&A section. And Dr. Gidwani, while I have you, I'll start out with some questions that are directed towards you, if that's all right with you. So the first one, Kathleen Roper, she loves the unasked questions that you described, and wants to know if you have family partners or other experience-based peers as part of your team.
So great question, thank you. We really have a continuum of services. So on our higher end program, we have family peer partners. So these are families that have been through and really they offer an added level. So when we think about our care coordination, we really have a continuum of services. On that higher level, we do make sure that we have peer partners who are paid. And those are parents that have been through the system or been through our programs. And I think that's just another added piece. In terms of the more navigation and more community-based, we haven't gotten there yet. We just had a grant that was not funded where we were going to partner. One of the interesting things about San Diego, much like the situation you all face, is we have such rich ethnic diversity and we have an incredibly huge refugee community. And so we have been working with partners in the refugee community. And again, one of the big issues that we run into, and I think something that we have to be really critically aware of, is how much trauma do our navigators and our home visitors have, and how do we help them with that? Because again, if you have unaddressed trauma and you're working with families, you will connect in a trauma bond, And really what we want to do is have you in the position where you can hear the family with compassion and not be so pulled in that you can't help the family move forward. So I am a huge advocate of community health workers. We have an incredible system of promotores here in Southern California, which we're incredibly proud of. And I'm one of the voices that says we need to make sure that their mental health is cared for and that they're cared for and supported. And so, as I mentioned before on supervision, we do reflective supervision. There's 3 types of supervision. There's administrative supervision, where we just make sure that you're doing kind of the paperwork in those pieces. There's clinical supervision, and this is also true for navigators. And then there's the reflective supervision. And I think, again, this is something that doesn't get paid for unless it's paid for through grants. And so, again, I really, I'm blown away by some of the folks that I've worked with. We have 6 home visitors out in our East County who are Farsi or Arabic speaking women who all were immigrant refugees themselves. And when they told me their stories, I did a focus group with them. I don't know how I stayed in my chair. They blew me away. They knocked me out with just how powerful they were in terms of their own experiences, how they resolved their own experiences, and then they want to help their community. So those are our best, most incredible individuals. And one of them, gosh, if I had an endowment, I would be paying for her to get her mental health credentials and keep her in a home visiting program and delivering mental health in the home, in the community. So again, I'm very disappointed that I didn't win that really big lottery, because that would be how I would be spending that money.
And Dr. Gigwani, the next question I'll direct to you as well. They're interested in hearing more about why pediatrician should be the leader in chief. While the most clinically knowledgeable, they're also likely the least available. So I wondered if you could riff on that a little.
So about 20 years ago, when I was doing my fellowship, I had really thought out a model of care. Ideally, in the model of care, what you would have is you would have a pediatrician who had a team of medical assistants, nurse practitioners, really working as a team to take care of the clinical side of work. But that team would be actually the smaller part of the team. The larger part of the team would be the community-based team that would have everything from parent partners to grandmas to other folks who were getting the key education and then the key skills to help their community. And so again, it would be a piece where the medical office really, in my perspective, plays a hub role to really build out pieces. Now that would require a lot of supervision, a lot of making sure the messages were good, just that kind of teamwork. But again, it becomes the team approach. So one of the things I would point to is models like Healthy Steps, where you have a developmental specialist in the office. And again, the pediatrician really could play a role of, when things are really medically complicated, they can be involved. But I don't see the pediatrician having to carry the whole load. I think there's different skill sets. I joke that when I was in practice, I would try to do care coordination. And there's 2 things that I noticed. One, I was the most expensive person from a salary perspective. So that wasn't a great use of my time from an economic perspective. But more importantly, I wasn't as skilled as a social worker. I wasn't as skilled as a referral coordinator. Also, many times I didn't speak the language. Again, when your primary language is not English, it's a little bit hard to explain certain concepts that require subtleties and body language and cultural knowledge. And so to me, the ideal setup is having folks who are from communities be a part of the team. And again, not an add-on, but a central part of the team. And so that's where I would say that, again, it's re-looking at the model of care, having it as a really team approach. Everybody has roles and responsibilities, but again, we utilize people who have the best set of skills to best serve families. And so again, it's really taking a team approach and saying, who do I need on the team to care for, not just the family that walks through the door, but the family who lives in my community.
Thank you. And I'll direct this next question to Dr. Paul. So this is a good question about service capacity of studios. So there's two parts. What strategies did the clinic and community provider partnerships use to address the challenge of service availability and supply? And Dr. Paul, do you want me to give you both questions now, or do you want me to?
Yeah.
Okay.
Bring it on.
All right. And the second question is, what feedback loops were there back to the clinic about services that families had accessed?
Back to the clinic, you said?
Yes.
Yeah. So those are great questions. And I think an umbrella statement that I'll make, and I should say Carolyn and Rachel, feel free to join in whenever, but I think that while we are seeing best practices, and even though that this collaborative has been going on and these programs have been in development and have been implemented for nearly 4 years now, I don't think any one of our interviewees would say, okay, great, we figured it out. Like, we have this nailed down and we are in a sustainable kind of permanent state. I think this is very much in flux. And I say that prior to answering this question because it's just really difficult work, and it requires, I mean, to Dr. Gidwani's point, like, you have to fund people. I think, like, since I've been involved in evaluating programs and initiatives like this, there's been so much emphasis on, building big data systems and funding, data connectivity projects. And I think that is all very important, especially across healthcare settings and so forth. But I think it's also really important to fund people. And I think that piece is missing from this work. And so, and Dr. Gidwani was just talking about staffing for programs like this is all often dependent on community health workers, people who are often from the communities that they're working in, these are the people who families, parents in particular, trust and want to talk about these issues with, and yet the resource issue is real. And none of the programs that we're evaluating, even though they are very much kind of on the forefront of this field, I would say, of this sort of nationwide focus on this social determinant of health screening and referral work, none of them have kind of in-house sustainable funding to the point where they feel comfortable, like they're okay. And I think that the other side of that, which you're getting at, is the community resource piece, which is often even more fragile than some of these physicians. And so, the pandemic, that's one of the reasons we applied for this grant opportunities, because we know from the brief round of interviewing that we did right at the beginning of the pandemic that Rachel mentioned, that that need among families was high prior to the pandemic in these clinics, and just skyrocketed, especially for things like you can imagine related to income, like food insecurity. And so they had to, in many cases, clinics had to form new partnerships, and at the same time, community-based organizations had to apply for additional resources. And so we know that some CBOs in this network, in this collaborative network, were successful in securing additional grants from local organizations to increase the supply of their food pantry. And that was really critical to meeting the needs of families. And so there's not a simple answer to that question. I think it's a really complex, system-wide issue, and really requires effort on the part of individuals. I mean, people stepping away from business as usual to say, okay, I need to now focus on this grant application, otherwise we're not going to be able to feed all the families coming to our door. And so that's a big piece of it. And the feedback loops are difficult to establish, as I mentioned. I think one site that we actually did, it was one of the 4 sites that we did an in-depth process evaluation, including series of site visits to. They had a great system set up using smart sheets with their CBO. their CBOs, I should say, multiple. But it was sort of a unique situation in that it was a single clinic, kind of a standalone peds clinic that had, and so therefore the lead at that clinic site had a lot of freedom with respect to what they could do for this collaborative. And they really, powered forward and implemented Smartsheet system and used that to communicate with their CBOs. And that worked really well for a while until recently, and Rachel, correct me if I'm wrong, I think that they had to stop using Smartsheets because of a larger hospital mandate. So that's a really complicated piece of this, but we know that it's critical for just effective program implementation for providers to understand when the needs of patients are being met in the community. So very important issue, very important issues, but both of them are quite complicated. Anything to add, Rachel and Carolyn?
I think every site and CBO partnership have their own strategy for communication. So some had a plan to meet regularly every Friday. Sometimes the CBOs had a certain point person that the clinic could communicate with directly. So that was how they kind of got that feedback loop. So every site had a different strategy, and but it was probably the most challenging part of the program, I would say, is actually hearing about what happened to those families that got referred.
Okay, so I'll move from that broad question to one that's a bit narrower and open it up to the NYU team. What screening tools were used specifically, and what was the process to determine which screening tools were used?
Rachel, you might be, I'll kick things off and then you can fill in as needed. But I will say that some clinics had tools built into their system. So like SWIC or Prepare, but I would say across the board, if they started using even like an amended version of Ochin's tool, they would adapt it for a pediatric clinic setting, of course, but then even further, we saw throughout the course of the first phase of our work with these sites, they really changed what they were screening for and narrowed the focus. Going back to an earlier point of people want to be, people who are implementing these programs want to screen for things that can be addressed in some way. And so so that became really important and caused sites to further amend tools. So I would say, maybe important to use an existing tool as a starting place, but then really just do the work to understand what is needed by the population you're serving in the clinic, and on the other side of the same coin, what your community partners can offer in terms of services.
Yeah, I'll just add, I know a lot of the sites started with the Health Leads screening tool and use that kind of as a guide, but it really took a lot of testing, piloting the screening tools, and then revising them, and then revising them again and again, and also editing the language to what worked best for their target population. So it's an ongoing process to perfect the screening tools.
And I'll just add one more thing, and that's that the requirements of the grant from the site's perspective were that they had to use a tool systematically, and that they partner with community-based organizations. But that's the only real requirements that they had. Within that, the sites had a lot of freedom to, they were encouraged to use existing tools that were to some degree validated, but also encouraged to tailor them. So there was no attempt to use one tool across all the sites. That was neither required nor particularly encouraged.
Mm-hmm.
Makes sense. So the next question is from John. Did you give feedback during your study of any findings to improve implementation And do you have views on this type of action evaluation approach?
Yeah, I would say, we haven't talked about our evaluation work as being, officially, formative evaluation, but it was. I mean, we were in constant communication with sites, and during the first phase, especially as they were getting things up and running, part of our role was actually to be available to sites for technical assistance. And so we were not only kind of providing feedback along the way, but also helping them with very specific questions that they had related to their own, for example, data capture systems. And so I will say that during the that feedback loop looked different during different phases, but one constant prior to the pandemic was that we had regularly scheduled face-to-face collaborative wide meetings throughout the year. And so that was not just for the sake of the study team and the sites, sites being clinics and CBO partners, but also for a broader network of partners in the community. So we had people from state and local public health. There was a Medicaid managed care payer who was there, represented there in the room. The New York City Health and Hospitals has an Office of Population Health. They were represented. And so really key figures from a system perspective came to the collaborative to understand what was going on. And in some cases, they presented and interacted in their own way. But so that venue was a key structure that was in place that allowed us to provide information back to the group as we learned about it. During the process evaluation phase, where we visited those 4 sites that Rachel talked about, we developed a series of site-specific program memos or site-specific memos after each site visit. And so those memos were drafted by us after the site visit, but then we shared them with sites to make sure that they were accurate. And each of those included their own perspective on areas for improvement, as well as any observations that we had gathered across sites. And so we've been kind of careful to present not only areas for improvement, but also share best practices across sites. And the sites themselves did that at these collaborative meetings. I think one of the most valuable things about those face-to-face meetings was having all the players in the room able to talk to one another. And often we would have extended troubleshooting conversations just to identify, allow sites to voice issues that they were having and sort of use the mind of the larger group to address that issue and come up with a new strategy or workaround. And so that's where some of the things that I mentioned, like the issue with missed positive screens, missing people who had needs but weren't responding to the screening tool, that's where those kinds of issues came up. And so I would say that's not only something we did, but something that was really critical to the implementation of each of the programs.
Great response, and we're going to try. I'm going to try to squeeze in 3 more questions, if that's all right with the presenters. You think that's doable?
Sure. Yeah, I'll try to keep it brief.
All right. So Ellen would like for you to speak to cross-sectoral referral and coordination with education system coordinators responsible for child and family services under IDEA Part C and newborn screening programs.
So part of the, I would say that this would only be applicable to sort of a small subset of the population that we were dealing with. Most of these screens were conducted at well child visits in a clinical setting. And so some of the clinics included their early childhood development partners in this collaborative and often not. And so I would say that we don't have a great lens onto the relationship between this collaborative and that particular piece of the chain. But I realize it's important, and in the site that I'm thinking of that did include their community partner for those services, we learned a lot from that one interview, but we did not systematically capture that information across sites. Anything to add, Rachel or Carolyn?
No.
Yeah. I think that's definitely an area of further research that with a explicit focus on that.
And this next question kind of speaks to flexibility. So while each site had its own strategy, were you providing them with specific metrics to capture? And what has been the most helpful in understanding the progress and success of a referral workflow?
Yeah, it's interesting. As I was talking about those measures, it struck me that what became important was not the actual numbers from any given site. I mean, I think those are useful for the programmatic side, even more so than they are for us. We're going to take another deep look at that during our grant period for this project. But I think just the exercise of developing measures in partnership with sites, and so getting their feedback on what would be important to capture, as well as all of that work that we did with them in phase 1 on setting up systems to capture this information. I think it was quite shocking, frankly, for a lot of them to realize, oh my gosh, we have all of this administrative data, and yet we can't get a screening rate because there's no way to identify in our EHR what the denominator is for our target population. And so I think just getting a sense from them of how difficult some of these what we would think of as basic measures from an evaluation perspective are to capture, that was valuable for everybody involved. And then as we've sort of, I don't want to belabor the point, but I think we've talked about the feedback loop and how critical that is to program implementation, and realizing how, I don't know that we would have realized how difficult it was across every single site to capture that information had we not developed that as a core metric. And so those measures were valuable for a number of reasons, and pointing out, areas of, pointing out challenging areas for this kind of work is certainly one of them.
Okay, so in the interest of time, we're going to end the Q&A there. Of course, we'll follow up the slides, and if folks have any additional questions that they want to pose to the presenters today, feel free to reach out to the SFRA team. You'll have our email address from the follow-up. So thank you to the NYU team, Maggie Paul, Karen Berry, and Richard Masser, for sharing an overview of the study, and of course, thank you, Pradeep Gidwani, for the fantastic commentary as well. So a few announcements in closing. If you are interested in receiving a certificate of completion, we're interested in giving you one. So complete the survey at the end of the session. We'll also email one to you as well. And hopefully you enjoyed this webinar, and you'll be back with us for our next one on February 24th, same time, same place. It's another COVID-focused study looking at changes in capacity for CBOs to absorb clinical referrals during the pandemic. So these webinars are bi-weekly, on Wednesdays at 12 noon Eastern Standard Time. So with that, I just want to thank the presenters again, and we thank you all for joining us, and look forward to seeing you February 24th.